New Jersey, United States. I have the opportunity to discuss with my juniors, fellows, and seniors about localization in the nervous system. Before that, today I dedicate this lecture to Professor Akhtar from Dow Medical College, Civil Hospital, Karachi. Long time back in 1988-89, I had the opportunity to learn from him, through him. I rotated with him for about 4 months as a neurology resident. Localization in nervous system. Just like every other disease system, every other organ system, it is very important to pinpoint the localization, not only for academic reason, but more so for treatment and diagnosis purposes, and more comfortable to the patient and family if you discuss with them where is the lesion, what is the prognosis, and what kind of treatments are available. Well, let's proceed. Right foot drop. A person comes to you with sudden onset of right foot drop. Where is the lesion? Or a patient has both eyes deviated towards right. Where would you localize the lesion? What is the cause of the lesion? Well, crudely, you can divide or you can subdivide nervous system into multiple layers. Cortical, which is left and right, gray matter. Subcortical consists of white matter and other subcortical areas like caudate nucleus, internal capsule. Further down, brainstem, cerebellum, spinal cord, nerve roots, peripheral nerves, neuromuscular junctions, and muscles. Each of these 9 have their very specific and characteristics that we can easily localize and pinpoint lesions. More so, other areas like onset of the disease, age of onset, the distribution means it is focal or generalized, duration, intensity, frequency, associated features, aggravating features, and relieving factors, they all play a very, very important role in pinpointing the area, the etiology, and the localization. Onset. Onset could be acute, subacute, or chronic. Acute, the patient was very fine, and the next moment, suddenly, boom, there is a neurological deficit. Subacute, patient has these symptoms for a week or a month, and chronic for years. Age of onset, there are certain specific diseases run in infants, children, young adults, and very characteristic diseases to adults and seniors. They all, if we go through each directions or each specific headings, they assist us further to localize the lesion. Distribution, as I mentioned earlier, if the deficit is more generalized, means the mentation is also involved, or it is just focal. Is it more distal or proximal? Is it on ipsilateral, meaning on the same side, or are there some cross findings? Means some of the lesion on one side and the other lesion on the other side. Duration is the symptoms lasted for minutes, hours, or months and years, and that further localize our lesions as well. Intensity, the symptoms are mild, moderate, or severe. Frequency, in this way we can find out if the deficit or the symptoms are constant, means all the time, or they just come and go. Associated features, fatigue or fatigability. Diplopia means double vision, or patient has shortness of breath. They have difficulty ambulating, going upstairs or downstairs. Is there any speech or language deficit, or any associated pain or numbness, paresthesias, and there are much more. Aggravating factors, what are the reasons or conditions that exacerbate the lesions? Is any exertion problem or posture related, any metabolic syndromes related, any electrolyte imbalance, infections, and many more. Relieving factors, the symptom resolved with rest or just adjusting the posture. Continuation of the exercise may improve the condition, which is a very characteristic localization. Management of metabolic conditions. Now, characteristics. As I mentioned earlier, very early in our debate, that every localization has its own characteristics. Starting from head to toe, it's like dominant hemisphere, which is usually the left hemisphere. Cortex has a different presentation. Same time, non-dominant hemisphere, usually on the right side. Caudate nucleus is a very important role in some of the movement disorders. Basal ganglia, internal capsules carries your fibers from head to toe or from toe to head. Sensory fibers, motor fibers. Brain stem harbors all of your cranial nerves and further divided into 3 different portions. And not to mention is cerebellum, which is your fine movements and balance center. Characteristics of the spinal cord, motor neuron diseases, nerve roots, plexus, both brachial and lumbosacral plexus, peripheral nerves, namely median, radial, ulnar, or sciatic nerve, or peroneal nerve, the tibial nerve. Neuromuscular junctions have very characteristics of several diseases. We'll discuss 3 of them today, and muscle disorders. Okay. Is everyone with me, or someone has joined so far? Okay, let me continue this. Right hemisphere or right cortical lesions. Well, acute onset, chronic onset. Acute onset means if patients suddenly have a stroke, or chronically onset, patient has dementia, Lewy body disease, or normal pressure hydrocephalus. These are the conditions that can affect hemisphere, namely the frontal hemisphere, the temporal region, the frontotemporal dementia. In the right hemisphere, usually the speech is the one that is involved. Patients may present with dysarthria. So what is the difference between dysarthria and language problems, so speech and language problem? In a speech problem, patients can have correct grammar, correct sentences, but they cannot articulate properly. It means if you have a hamburger in your mouth and you try to speak, you can still speak right words, you can still speak right grammar, but the people may not understand you. So articulation problem. Mood and behavior, usually on the right side, if right frontal cortex is damaged, patients may behave like bipolar. Frontal eye fields are also, and we will discuss this frontal eye fields when the question will come that the eyes are deviated either right or left, where is the lesion? And this is one of the localization. Especially most of the time in hemisphere, face, arm, and legs are involved ipsilateral. But you have seen that there are certain structures which are not involved in frontal or in hemisphere or cortical lesions. Like we don't see any cranial nerve involved down here. We don't see any tremors. We don't see any dysmetria or gait disturbance. Simultaneously, on the left hemisphere or left cortical area, the language is involved. Language we can divide into multiple, such as patient may have aphasia. There are different kinds of aphasia, such as expressive aphasia or Broca's aphasia, conduction aphasia. So every single aphasia has its own pinpoint or lesions. Again, mood and behavior. Frontal left cortical mostly give you depression. And again, face, arm, and legs are usually involved on ipsilateral, means on the same side. Move on further down, subcortical lesion. Subcortical lesion means you live in gray matter coming down to white matter and other structures such as basal ganglia, internal capsules, and caudate. In such case, you will see face, arm, and leg ipsilateral, but you may not see speech or language involvement. And mostly, you may not see any behavioral issues or frontal eye field problems. And if you can come down further down, brain stems, all the cranial nerves harbors in cranial, all the cranial nerves harbor in brain stem. Brain stem is further divided into three: midbrain, pons, and medulla. So if the question comes that the first cranial nerve, which is olfactory, is involved, patient has lost sensation of smelling. So where would be the lesion? We know that the first cranial nerve does not go to brainstem, so the lesions cannot be in brainstem. It is a cribriform plate just inferior to both frontal lobes with the lesion. But on the other hand, if someone has 7th or 8th cranial nerve involved, just like in mostly Bell's palsy, we can very much pinpoint the lesion. We can do the MRI of the brain and focus to pontocerebral junctions where, pontomedullary junctions, where the 7th and 8th cranial nerve exits. Or if someone has 9, 10th, or 11th cranial nerve exam, like the tongue involvement or swelling involvement, so we know that these cranial nerves are involved in brainstem. Furthermore, so far we have discussed everything ipsilateral, but now when the fiber comes to brainstem, either coming from the spinal cord going up, or from the cortex and internal capsules coming down. So these fibers cross in brainstem. When these fibers crossing, it means that you have sensory fibers on one side, motor fibers on the other hand. At the same time, you have facial involvement on ipsilateral and rest of the body involved on contralateral. So if the patient has a pupillary defect, or patient has a facial weakness, we can very specifically involve, if we know the anatomy, where the 3rd, 4th, and 5th cranial nerves involved, whereas 6th, 7th, and 8th cranial nerves are coming from, and the last 9, 10, 11, and 12 cranial nerves, where are they harbor. So these are the 3 different divisions of brainstem. Further down, cerebellum, a very unique brain, some people call it small brain, is harbor a very fine movement. So whenever the motor message goes from the spinal cord to the central nervous system, they go through cerebellum called spinocerebellar tract, which modify and put a fine movements in those motor responses. When these cells or these tracts are damaged, patient gets ataxia, dysmetria. Another thing is normal strength. However, patients presents with weakness. They may say that, doctor, I am weak on my right side. So patient is unable to stand. Patient is unable to walk properly, a straight line. If very specific part of the cerebellum called vermis, if the vermis is damaged, then patient has a truncal ataxia and titubation. However, when the same person sits or lies in bed, the motor strength is 5 out of 5. It means they are not weak in motor-wise. However, when they try to stand or pick something or try to walk, they present weakness, which is more dysmetria and fine movements difficulty. Further down, spinal cord. Face is out. Excuse me for my misspelled word. Cranial nerves are out. Now, very specific, so far we have not seen sensory levels. So depending on what part, or is cervical region or thoracic region or the lumbar region, we have a very specific sensory levels. Plus, we also see cross findings. Remember, how would you differentiate cross finding between spinal cord and brainstem? Very easy. There are no cranial nerves involved in spinal cord. Face is not involved in spinal cord. And in brainstem, there is no sensory levels. Further down, motor neurons. Motor neurons classically present with both upper motor neuron and lower motor neuron together. Means in some part of the body, you'll see upper motor neuron symptoms like spasticity, exaggerated deep tendon reflexes. You will see Babinski's sign, which is plantar responses or dorsiflexion. On the other hand, in the same patient, either on the same limb or the different limb, you'll see lower motor neuron. There are no other diseases that present with both upper and lower motor neuron in the same person. Lower motor neuron flaccid, hyporeflexes, fasciculation, and atrophy. And if you remember, there is one disease called ALS, amyotrophic lateral sclerosis, which is typically present with upper and lower motor neuron disease. Roots, when the nerve or the fibers exit from spinal cord, before they merge into dorsal root ganglia, there are like a couple centimeters of spinal fibers that merge in to give a root, and root are very specific. I mentioned C5 to T1 for some reason, because these are the fibers that go to upper extremities, and L4 to S1, these are the fibers that go to lower extremities. So these are specific in such a way that if the roots are involved from C5 to T1, it is more focal, unilateral, very painful, and the pain radiates from neck down either to toes or fingers. And one more thing typical with roots, that each root has a group of muscles, myotomes, which are involved. So each root, C5 or C6, 7, they have own their specific muscles, those are involved. Like C5, only an examination, you'll see a deltoid involvement. In C6, you will see biceps involvement. In C7, you will see triceps involvement. And in T1, you will see involvement of small muscles of your hand. So you can, by a good neurological examination, very pinpoint where the localization is in upper nerve roots. Same thing in lower nerve roots, L4 to S1, you can pinpoint about which muscles are involved, and that will lead you to which nerve is involved and what level. Come down further, nerve involvements. Now, the difference between root involvement and nerve involvement is a little bit different. Number one, again, there's a group of muscles, but these groups are a little bit different. Let me give you an example. Like a radial nerve. A radial nerve has a participation of C5, C6, C7, C8, and T1 roots involvement. It means that there's a patchy involvement of different muscles from entire root. However, there are other C5, C6, and C7 muscles which are not innervated by radial nerve. They are innervated by either median nerve or ulnar nerve or musculocutaneous nerve. Those muscles will be spared in a single or mono nerve involvement. However, in root, if C5 is involved, it means every single C5 muscles, either it is in radial nerve or median nerve or ulnar nerve, they all will be involved. So that is the difference between a root involvement and nerve involvement. Plus, you will have some sensory finding And nerve pain is less painful. It is mostly achy, paresthesia, unless or until it is a small fiber neuropathy, which is painful, burning feet. Come down further, neuromuscular junction. As we know, the neuromuscular junction is the area where nerve terminates to muscle fibers. And the classic finding for this is fatigability, improved with rest. Now, when I say look for cancer, so before we look for cancer, let's discuss three common diseases involved in neuromuscular junction. One disease is patient wakes up very fresh. However, as the day passes, they start become fatigued and more tired, which is classic for myasthenia gravis. On the other hand, patient wakes up fatigued, but as the day passes, as he continues exercise, he becomes stronger and stronger, and that is called Eaton-Lambert or Lambert-Eaton syndrome. Well, if someone has a Lambert-Eaton or Eaton-Lambert syndrome, be careful and watch for lung cancer. It is justified to do scans or x-rays of the lungs. Also look for Horner syndrome on the ipsilateral side. Another disease that involves neuromuscular junction is botulism toxin. Patient remains fatigued no matter how much exercise, maybe a little improvement, but mostly they remain fatigued and tired as the day passes. The etiology and pathophysiology of all these diseases are different. Muscles, proximal versus distal, and looks for rashes, skin, again look for cancer. Now, it is classical for muscle diseases that involve mostly, now we are talking about an ideal condition, we are not talking about variants or uncommon conditions. There are three common conditions that comes in proximal versus distal weakness in adult and senior citizens. It is polymyositis, dermatomyositis, and inclusion body myositis. How would you differentiate between these diseases? One way is very specifically look for skin rashes. And if you find skin rashes, then obviously this would be a dermatomyositis. And it is warranted to look for cancer, especially the GI cancer in those patients or the breast cancer in those patients. However, patient in 40s and proximal weakness, you can diagnose comfortably with polymyositis depending on the levels of muscle enzyme, which are 5 to 10-fold increased. But it's another way to differentiate between polymyositis and inclusion body myositis is to treat the patient with steroids. If they are responsive, they're sure they are polymyositis, because characteristically inclusion body myositis patients do not respond to steroids or other disease modifying agents. So let's go back. Right foot drop. How would you locate the lesion? What kind of examination would you do, and how would you confirm your diagnosis? If you know the anatomy of foot, if you know the different movements of the foot, if you know the different muscles involved in your foot, and if you know the nerve supply, it's very easy. The one thing that you can learn today, and you can keep forever, that's most of the foot muscles are supplied by L5 nerve root. So, what are the muscles and what are the actions? Dorsiflexion, which is tibialis anterior. Eversion means like the foot is going outside. You fix your heel and turn your toes or the foot towards outside. That's peroneus, peroneus longus, peroneus brevis. And inversion, now you fix your heel and turn your toes or your foot inwards, supplied by tibialis posterior. And plantar flexion means like pushing the ball of the foot down, just like you're applying brakes or accelerator. This is gastrocnemius. So, 4 movements, 4 muscles. How would you differentiate which muscles are involved? And on the basis of these muscles, you can say where is the lesion. Very simple. Just learn it today. If a patient comes with a foot drop and you examine, patients can perform eversion, inversion, and plantar flexions. Means the only deficit is in dorsiflexion. Means tibialis anterior is not working. Rest of the muscles are working. We should know that tibialis anterior is supplied by deep peroneal nerve, which is a branch of the common peroneal nerve. Common peroneal nerves combined with tibial nerves to give sciatic nerve, or vice versa. The sciatic nerve divides into 2, the tibial and common peroneal, and the common peroneal further divides into superficial peroneal and deep peroneal. So, if tibialis anterior is gone, means dorsiflexion is gone, means patients cannot lift their foot. The lesion is deep peroneal nerve, which is just distal or approximate to a fibular tuberosity, just distal and lateral to your knee. And you can feel, everyone can feel that bone. However, if the same patient cannot do eversion, means the patients cannot turn the foot or move the foot towards lateral side. The patients can do inversion and plantar flexion. So now the 2 muscles are involved, tibialis anterior and peroneus. Peroneus is supplied by superficial peroneal, so it means there's a lesion in a common peroneal nerve. Common peroneal nerve again divided into superficial and deep peroneal nerve. Superficial is peroneus, deep is tibialis anterior. Both are gone. It means a lesion in common peroneal nerve. Common peroneal nerve again very superficial against the bone, against the fibular bone. It is just approximate or proximal to tibia fibular, the bone that you can feel on your left leg, tuberosity, the fibular tuberosity. Okay, move on. Same patient cannot do dorsiflexion, cannot do inversion, cannot do eversion, but can do plantar flexion. So now 3 muscles are involved, tibialis anterior, peroneus longus, and tibialis posterior. Tibialis posterior is a branch of tibial nerve. So now the tibial nerve is involved and common peroneal nerve is involved. So 2 possibilities. Possibilities may be the 2 separate lesions that involve common peroneal nerve and tibial nerve together, which is unlikely. You may see in the books, but not in practical reason. However, sciatic nerve, and the sciatic nerve divides into tibial and posterior. So the lesion in sciatic nerve can give you the scenario that patient cannot do dorsiflexion, eversion, or inversion, but they can do flexion. Sciatic nerve is painful, gives a lot of pain, posterior to the thigh, running down to the leg. However, if the patients cannot do any movements, the foot is just dead, hanging down, no flexion, dorsiflexion or plantar flexion, no inversion and eversion, it means every L5 nerve is involved. And when L5 nerve is involved, it means the lesion is very high. And where is the lesion? The lesion is up top L5 nerve root. So I hope, I guess, that everyone will learn how to differentiate, diagnose, and localize foot drop. Next important thing, both eyes deviated to the right. Since we have time, we can discuss this. Frontal eye field, left cortex, right cortex. The function of the frontal eye fields in the frontal lobe, they push the eyes contralateral, means the right cortex push the eyes towards the left, and the left cortex push the eyes towards right. That's why we are comfortably seeing in the front. Now, if the eyes are deviated towards right side, there are three possibilities and clear-cut three localizations. If the eyes are deviated to the right, it means that right cortex is not working. Therefore, the left cortex has dominant situation and they are pushing eyes towards the right. The most common reason is stroke. There could be other space occupying lesion, but most likely it is sudden onset. Patient has a gaze preference. Just remember the word preference because I'll tell you the difference between preference and palsy, and there's a two different localization. So patient has a gaze preference, they are looking towards right. It means they are looking towards the lesion. If the stroke is on the right cortex, patient's eyes move towards the right, most likely the lesion is the frontal because the frontal eye field and patient is looking to the right. However, if you do MRI of the brain and you don't see any lesion in the cortex, the eyes are still moved towards the right side. And if you notice, you see there is some nystagmus in the eyes. So what happened this time? Very simple logic, it's not a rocket science. It means that the right hemisphere somehow becomes more stronger to the left side. Means right is pushing, let me reverse here. Somehow the left cortex becomes so strong as compared to the right side that the left cortex overcomes the right cortex and pushing the eyes towards the right side. It means something happened to the cells of the left hemisphere or left frontal cortex that's so forcefully pushing the eye towards the right side. And there's one condition called seizures and epilepsy, when the nerve fiber or the axons or the neurons are hyperexcited in epilepsy or seizures. You may not see any lesions, but because of that activity, the eyes are deviated to the opposite side. So in a stroke, the cortical stroke, eyes move towards the lesion. In seizures, eyes move opposite, contralateral. And I give you the clue to nystagmus because nystagmus is showing that eyes are trying to turn back to its original position, but because of the hyperactivity, they are moved away or they move contralateral. And if you do EEG, you may see some spike rates or you may see epileptic discharges. So you did MRI of the brain, you did not see any frontal lesion. You did EEG on this patient, you did not see any seizure or seizure activity or epileptic discharges, but the eyes are still deviated towards the right side. So now where the lesion is. So look very carefully in MRI of the brain, and now you come down and you see that the patient has a lesion in the brainstem. Brainstem lesion, the fibers have already crossed. So again in the brainstem, eyes move towards the opposite side. So there are two conditions when the eyes move towards the opposite side, seizures and brainstem lesions. And on cortical lesion, eyes move ipsilaterally. I mentioned earlier what's the difference between gaze preference or neglect, and gaze palsy. Well, preference means that patient prefers to look on one side. However, if somehow you can make it happen that the patients can bring their eyes to the midline, but they prefer to look on one side. This is called preference. Palsy, no matter what you do, patient will not move the eyes to the midline. And this is characteristic. Gaze preference denotes as a lesion of frontal cortex, means the stroke in the front, and patient have a gaze preference, they move the eyes. However, gaze palsy is a lesion of brainstem. Well, I think this is good enough for today. If anyone has any questions, any concerns, or any input, you're welcome.
Any questions, please? Hello. So if anyone is muted, so let me know in chat if you have questions, so I will unmute you then. Do we have questions from King Edward? Do you rush it up? Hello. Ji Rashida, please proceed. You can ask the question. You have the mic. I have unmuted you, so you can ask. Ji Do, you can ask. Please use your mic, or if you prefer chat, it's up to you. You can ask either ways. Ji Do University. Dr. Saab, there's a question in your chat from DUHS.
Okay, let me see. We have a question. Can't six-nerve palsy have gaze effect? Okay, I can talk?
G, please. Yes, please.
Okay. Not only six-nerve palsy, but there are three nerves. 3, 4, and 6 nerve, they all supply external ocular muscles. However, just remember, I told that both eyes, 6 nerve palsy can have one eye deviated, like its lateral eye can be deviated. If you remember SO4, LR6, so lateral rectus is involved in cranial nerve 6 palsy. However, it is a unilateral. It is a very valid question, but again, to differentiate between a bilateral gaze preference or palsy versus a unilateral, plus 6 nerve palsy is more peripheral lesion as compared to gaze preference and palsy, which is more central lesion, either nuclei is involved or the cortical is involved. Is this satisfying enough?
GDO University. Yeah, he says thanks. So we have another question from King Edward. Dr. Saab, it's in chat. So,
King Edwards, I've not seen yet.
Yeah, it's key. So it's like it's sent to me, so I'll read it for you. Is there? So okay, so I'm gonna forward this to you. To present. Yeah. Yes, I have forwarded it to you. G.
Is there an ipsilateral finding in a cortex lesion? Is there an ipsilateral finding in a cortex lesion? Okay. Any lesion above the brainstem, just remember, any lesion above the brainstem, it is a cortical or subcortical, basal ganglia, internal capsule, all the lesions are ipsilateral. However, once the fiber comes down in brainstem, especially pons and down, the fiber is starting crossing, and then we get it ipsilateral and contralateral findings, crisscross findings. Again, any lesion above pons is ipsilateral. The lesion pons and below, they are cross findings. Is this okay?
There's another question.
That's a question from me for the participant.
Oh,
What is the most common reason for cranial nerve 3 palsy? Either pupil sparing versus pupil involved. Anyone has a courage? Answer is okay. Another lesion. Someone has a wrist drop. Wrist drop means you have a lesion in radial nerve. Triceps is a muscle supplied by radial. There could be two conditions. One condition is called absent triceps reflex. Second condition is tricep reflex is present. So how would you differentiate where is the lesion? Well, there is a spiral groove in humerus. If the lesion is distal to spiral groove, your tricep reflex will be present. However, if the tricep reflex is absent, means that the lesion is either in the spiral groove or just proximal to the spiral groove. This wrist drop is called like what? Saturday night's palsy, that suddenly patient wakes up with a pressure on the spiral groove and sleeping, and suddenly they wake up with a wrist drop. Anything else?
Okay, do we have more questions?
It's a very, very interesting disease that I just mentioned, the lesion in which you will see ataxia, urinary incontinence, and dementia. Many people, and I'm sure that many people in Pakistan have this disease. It is a pretty much older patient, above 50s and 60s. They have, initially they start with incontinence and ataxia, and then later stages, then they suddenly become demented. Dementia should come last by definition. If dementia comes early and then ataxia incontinence, then this is not the disease. The disease is called idiopathic intracranial hypertension or normal pressure hydrocephalus. In normal pressure hydrocephalus, the lateral ventricles are very enlarged. However, if you do lumbar puncture, the pressure is normal. But why the patient has ataxia, incontinence, and dementia? The frontal lobes are compressed with the enlargement of the ventricles, and bladder fibers, mood, memory fibers, and gait fibers, they all three together lie in the frontal area. So when the lateral ventricles are expand, they push these three fibers. And how would you finally diagnose these patients after doing CAT scan or MRI? You do lumbar puncture. And in lumbar puncture, you do large tap. Large tap means you take out about 10 to 12 cc's of fluids. And there's a dramatic improvement, means patient comes to your office, comes to your clinic, comes to the hospital with ataxia, incontinence, and dementia. You do lumbar puncture, take out about 15 cc's of CSF, and surprisingly, ataxia resolves. Dementia may or may not resolve, but most likely ataxia will be resolved for either a few hours, for the day or two. This also dictates your treatment. If ataxia resolved after a large tap, then this patient qualifies for VP shunting, ventriculoperitoneal shunting. Somehow you diagnose the patient and patient shows very minimal or no improvement, then that patients usually do not respond to VP shunting. This is also very interesting, RAPD.
There's a question from Dow. There's another question from Doe. Okay, do we have more questions from any university? Please let me know. All right.
So what is RAPD? And what are we dealing with? Where is the lesion? RAPD is relative afferent pupillary defect, means we are dealing with optic neuritis. And the way that you diagnose it, that when you swing the light, when you shine the light, when you shine the light on contralateral eye, suppose the patient has RAPD on the left eye, and you shine the light on the right eye, both the pupil, left and right, will constrict because of consensual eye reflex. But as soon as you swing the light to the left pupil, instead of remain constricted, it's enlarged or dilated because the fibers are damaged. It's called RAPD. It is a characteristic of optic neuritis, many conditions, and 50 to 60% of people who have optic neuritis may develop to multiple sclerosis. And there's a big debate that patients who have RAPD should, or optic neuritis as a diagnosis, should we start the patient on disease-modifying agent for MS or not?
Okay, we don't have any more questions. Yes, Dr. Arif, we don't have any more questions from any university. Yeah, so. All right, thank you everyone. Thank you, Dr. Arif, for being here. Thank you so much. So the recording for this lecture, I'm gonna make it available, and I'll email you the URL for the recording. All right, thank you everyone.
Thank you.
Thank you. All right, bye. Khuda Hafiz.
Khuda Hafiz.